Good morning, everyone. Welcome to Midwife Monday. Thanks for joining us today. One question that comes up a lot in our practice is about genetic testing. And there's genetic screenings, there's diagnostic testing, and oftentimes people will come into our practice that have already been seen by another healthcare provider, usually within the medical model of care, right? Maybe they've started with an obstetrician, and I'll say, what tests have you done? And the response generally is, I don't really know. I'm not really quite sure what they did. But blood was taken, and there's a lot of confusion as to what tests were done. And the way we talk about things here, and generally in the midwifery model of care, I think you'll find this pretty much across the board, that midwives give informed decision making. So there's a lot of conversation around what tests are available and which ones you would consent to or not consent to. Always remembering that you have a voice in your pregnancy. You always get to ask questions. What is that test? What will we learn? And how will it help us move forward? That's what we always talk about in our practice. Not whether or not, we try to avoid opinions about it. We try to avoid good and bad, you should or you shouldn't, you're allowed or you're not allowed. That language, we try to avoid it when possible. And when I do use it, I hopefully I can catch myself using it and correct myself, but we're not perfect. So what we always talk about in our practice is, like I just said, what tests are available. You will always be offered everything that is done in the doctor's office. You will be offered in our midwifery practice. We have the luxury of time in a midwifery practice versus the obstetrical model where the patient load is much heavier. They don't have as much time to customize. The liability is significantly higher. It's just a different model. It's not that it's a bad model. It's just a different model. So often when you go into your care provider, if they're not midwives, they don't have 60 minutes to sit with you face to face to answer all of your questions, right? They have about 3 to 5 minutes to get through your questions, make sure the baby is, is doing well, because they have a room full of patients out there in the waiting room. So it's not that their desire is not to give you the information, at least I don't believe that is the case, but that it's really unattainable when you have a large volume of people, and there's a lot of reasons why we practice medicine that way in the United States, and that's a whole other conversation. But in our practice, we always say, this is available, this is what we're going to learn, how will it help us move forward? So the biggest question comes up when we talk about prenatal, well, this is one thing, this is a prenatal genetic testing chart that we talk about when certain tests are available, and when we would do them and what we're going to learn from them, and the difference between genetic screening and diagnostic testing. And some of you, and certainly in the state of California, are familiar with this booklet. It's called the California Prenatal Screening Program. And this covers basically what this little infographic will show. And this is linked to the bottom of our Facebook feed right now. And then there's another lab that we use, but there are many labs that do this other test called NIPT, non-invasive perinatal testing. And this is a screening, but it has more accuracy than this screening. The California Prenatal Screening Program, this is if you have insurance, this is we say it's a free test, but it's covered by insurance. So it's not that it's free, because if you don't have insurance, you would be charged for it. But if you do have insurance, no matter what your insurance, it is covered by your insurance. And the first part of this test starts at between 10 weeks and 13 weeks. It's like 10 weeks, 6 days, and 13 weeks, 6 days. So we say between 10 and 13 weeks, you would do the first part of this screening. And it's what it entails is a blood test. And it's looking for some hormones in your blood that are identifying a risk factor. Initially in the first trimester, it's looking for risk factors for Down syndrome. You can also combine this first trimester blood test with an ultrasound, an early ultrasound. And that would be measuring the back of the baby's neck. That's called an NT scan, or a nuchal translucency scan. Nuchal means neck. So in the first trimester, there's an ability to measure the back of the baby's neck to be a marker or a risk factor for Down syndrome in combination with this blood test. That's the first part of this integrated prenatal screening program. Then the second part of the blood test is between 16 weeks and 18 weeks. And we would do another blood draw, and that's looking for 4 different things. It's looking for trisomy 13, 18, 21, and it's also looking for neural tube defects. And then you would also, in addition to the blood work, you would then do your big anatomy scan. Ultrasounds, I'll touch on that in a minute, but right now we're just talking about the blood work. So many people get very confused. So there's genetic testing. When this blood work from the California prenatal screening is done, it's looking for fetal abnormalities, right? Baby, things that are going on with the baby, not things that are going on with the pregnant person. That's called carrier testing, and that's a little bit different. So if you have a certain ethnic background, you might be offered carrier testing. So if you're Eastern European, so if you're a Jewish person and you're of Eastern European descent, you might be offered what's called carrier testing to look to see if you have a ethnic predisposition to a disease like Tay-Sachs, right? So that is prevalent with Eastern Europeans, especially if you have an Eastern European partner. The two of you might be carriers for this particular disease, which would then make the baby have a high risk for having that disease. So there's something called carrier testing. Carrier testing is looking at my genetics, looking at the pregnant person's genetics. If you're African American descent, it might be looking for sickle cell. If you're Eastern European, it would be a test looking for Tay-Sachs, among other things. If you're Mediterranean, I am of Mediterranean descent. I'm Italian. I can trace my background. I know that's where I'm from. There's not really anything genetically that I should be checking. Most likely I have the MTHFR gene deletion. We don't test for that in our practice because we know 30% of the population probably has that gene deletion. So we just treat everyone as if they have the MTHFR. We don't test for it in our practice. So in my pregnancies, I didn't need to do any carrier testing, even though my partner, my husband, is of Eastern European descent. Because I am not a carrier, I would not be a carrier of a certain disorder of people of Eastern European descent. We didn't need to be tested because our babies could not have presented with sickle cell, for example, because both partners have to be carriers in either for that representation to show up in the baby. We have had people come up when we do a newborn screening, which is a separate test that's done on the newborn after the birth. We've identified a couple of babies that are sickle cell carriers, and ironically, their parents are not African American but of Hispanic descent. But we've tested, and only one person is the carrier, so that gene cannot be fully represented in the baby because only one person is a carrier. Okay, so when you're pregnant, there are 2 types of testing. There's carrier testing that's looking for the pregnant person's gene situation. And then there's genetic testing that is done on the pregnant person, but it's pulling information to identify if there's any genetic anomalies in the baby, okay, not the mother. So those are 2 types of tests that can be offered to you. You have the right to decline any of this testing. Carrier testing, we think if there's a risk factor, if you are of a certain ethnic predisposition, we think carrier testing is a pretty good idea because it can give us an indicator if this baby might have very severe abnormalities that may or may not be compatible with life. So there's some information that you might want to gather by doing that carrier testing. Some people will choose to do carrier testing before they become pregnant. I think back when, certainly I've been married almost 26 years, so we didn't need to do any testing when we got married. But I remember historically, and some people can maybe chime in on this, like perhaps when my mother was getting married, that there was a time when people would get tested to check their genetic makeup before they had babies, like before they got married. There was something about that, but I don't know a whole lot about that because it certainly wasn't in my generation. And it's not currently in the current generation of people getting married. But if you are married and you're thinking about getting pregnant, you might want to do some carrier testing to give you some information about some characteristics you might carry. Once you are pregnant, then that's called the genetic testing. You have the right to decline genetic testing. Many people don't know when they're in the medical model that it is an option. And I am not saying you should decline it or you should absolutely do it, but we are certainly about that informed decision making. So the information we're going to learn with genetic testing is the baby at a risk for having one of these trisomy problems? Trisomy means 3 chromosomes versus 2 chromosomes, trisomy. So most prevalent is Down syndrome. So let's just touch on that, for instance. So if you do this carrier testing and you identify that the baby has a risk factor for Down syndrome, our question is, what are you going to do with the information? If you're going to carry this baby and go full term and birth a baby that potentially has Down syndrome, then we question whether you need to know this ahead of time. Some people choose not to know ahead of time because they're not going to do anything with the information. They would not choose to terminate a pregnancy. They were going to carry their pregnancy full term. So for them, it isn't going to be a decision maker for whether they're going to carry the pregnancy to term. Some people say, well, I would like to know to be prepared if the baby does have a chromosomal abnormality. So then there's another test that can be done. There are a couple of ways to go about it, actually. You could do diagnostic testing, which if you look at the infographic that we're going to link on our Facebook page, it talks about, it's called CVS, chorionic vili sampling, or amniocentesis. Both of those are invasive testings. So the genetic testing that is a screening is a blood draw from the pregnant person. We assess the blood work, it comes up with risk factors, and it either says, yes, you have a risk factor, no, you don't. Chorionic vili sampling, CVS, or amniocentesis, those are two. One goes in through the cervix. The chorionic vili sampling goes in through the cervix, so it's a vaginal, goes in through the cervix, gets a little bit of the villi, and then analyzes it, and that's actual genetic material, and that is 100 or 99.9% accurate. The amniocentesis is when you get a little bit further in your pregnancy and they do the needle through your belly and they pull some amniotic fluid out and they analyze the amniotic fluid. I can tell you in my practice, I actually have no recollection of anyone doing either a CVS or an amniocentesis. They're not done very often, certainly not within our practice, but that is actual genetic material. So that is available to you if you have a strong feeling about whether you would carry your pregnancy to term or not. So a lot of people say they want this information, the genetic screening, so that they can go ahead and they want to be prepared for when the baby is born. So that's when we go to anatomy scans. So ultrasounds are a way to identify some physical abnormalities if they are present within the baby. We do like in our practice that anatomy scan, which is between 19 and 21 weeks. We think we get a lot of really good information from that scan. You do have the right to decline that anatomy scan if you want within our practice, but we talk about how it's non-invasive and it will give us a lot of information, not just about the baby, but about the pregnant person's body as well. It lets us know where the placenta is implanted in the uterus. It lets us know how long the cervix is. It lets us know if there's a problem with maybe the placenta is being implanted over the cervical opening. Now we're not going to do anything with that information immediately. We're going to keep our eye on how that placenta is moving away from the cervical opening. So there's a lot of information we can gather that can help us throughout the pregnancy, kind of manage the pregnancy and help make sure you remain low risk. It also might inform us whether or not we would actually have an out-of-hospital birth. For instance, if you have a baby that we've identified has a physical anomaly, say there's a heart condition, that's not going to be picked up. It's not genetic necessarily, right? So it hasn't been picked up in any of your prenatal screening blood work, but when we do that anatomy scan, say the heart's on the other side of the chest, right? Or the great vessels are transposed, or there's something going on with this heart where we identify it, and we say, well, when the baby is born, we're going to want this baby. The baby is totally compatible with life. The baby just is going to need just heart surgery when it's born. So we would absolutely say, let's not have an out-of-hospital birth. That's not in the baby's best interest. let's deliver at a high level facility where you can hopefully have the birth you want. You can still have a vaginal delivery, but then we can either get that baby right into surgery or transfer the baby to a level hospital where we think that surgery would be best performed, right? It gives us information on how we want to proceed with the birth. So we do think that anatomy scan is very useful. A lot of people talk about early ultrasounds, and they'll come into our practice transferring care at maybe 12 weeks prenatally. They're already transferring care and they've already received 2 or 3 ultrasounds. And we always question, what is the benefit of those early ultrasounds? What information are we getting? How is it going to help us make a decision, and how is it going to help us move forward? There's not a lot of studies being done on multiple ultrasounds. The American College of Obstetrics and Gynecology, their link is below this Facebook feed as well, talks about there's no long-term studies on multiple ultrasounds. So we do know that we want to restrict those ultrasounds to medically necessary, and we want to restrict those ultrasounds to being done by a medical provider. It's very tempting to go to these third-party companies that do like a little peek in there, and they do keepsakes where you get to see, 4D, and you get to see a picture of the baby, and you want to bring family members, and they're really fun. And I get wanting to peek in there and see that sweet little baby in there, but the evidence isn't really behind it. So we're not big proponents of lots of ultrasounds. We really do like to stick to one ultrasound. There is, if you look at the statistics, back in 2009, only 67% of people had one ultrasound. 67% of people in 2009 had one ultrasound. In, I think currently, I forget when it was probably like 2015 or something, 98% of people had 3 or more ultrasounds. That is a giant difference. I know in my pregnancies, I have a 20-year-old and an almost 23-year-old, and I had one ultrasound. And actually with my second, I almost didn't have any ultrasounds. I was going to decline my anatomy scan, and then I decided to do it. But I was only offered really one ultrasound in my pregnancies. It wasn't something, certainly midwives don't often do confirmation of pregnancy ultrasounds. That's that transvaginal ultrasound that's done at 8 weeks to see a heartbeat, and then you go back in 10 weeks to see if the heartbeat is still there. And then you go back at 12 weeks, and now they can do the genetic testing component, right? The NT scan. So we often say, if you want to see what's going on in there, let's wait until the 10 to 13 week mark when we can do the NT, we can obviously confirm the pregnancy. And it's also a great time to date the pregnancy. If you had irregular cycles, you weren't tracking, you happened to be on birth control when you got pregnant, you just don't know how far along you are, we recommend, well, let's wait till that 11, 12 week mark. We think is a really good time to do that because A, it's excellent for dating. We know the accuracy is pretty darn good. Doesn't mean that's when you're going to have the baby, but we know that the date we get with that 11-week ultrasound is within that 5-week window, right? Your birthing season between 37 and 42 weeks. We know we have a pretty good time frame versus when you do an anatomy scan between 19 and 21, we don't date a pregnancy using those measurements because those are plus or minus 2 weeks. They're not accurate for dating a pregnancy. And certainly 3rd trimester ultrasounds, they can be very off in terms of estimating fetal weight or gestational age and things like that. So in our practice, we tend not to do 3rd trimester ultrasounds unless there's a very significant reason. We're doing a follow-up from an anatomy scan and we need to still gather more information. But maybe at 36 weeks, we'll do a quick confirmation that the baby's head is still down, but we're not doing any measurements unless we get to past 41 weeks. Now we're looking at amniotic fluid, breathing efforts, and things like that to establish whether the baby's environment is still acceptable and the baby can you can still stay pregnant, right? It's called post-dates testing. We do ultrasounds, there's enough fluid, the baby's doing well in the environment, and we can continue to be pregnant. So a big recap on this really technical Facebook Live today is there are 2 types of testing. There's genetic screening, then there's diagnostic testing. There's carrier screening, which is identifying issues with the pregnant person and her genetic background. Then the genetic screening is identifying whether there's any genetic anomaly with the baby. Then there are ultrasounds that can back up some of this information. The testing can start between 10 weeks and thereafter. We are going to link below to this infographic. I think this is pretty good information from ACOG. Then this is the California Prenatal Screening Program. When you come into our practice, everyone gets the booklet. Then we happen to use a lab called Sicignano. Cold. That was my Long Islandism just popped out there. This test is called Sicignano, and we really think it's a good idea because it's really accurate, but you don't really have to do it if you don't want to do it, but we think it's kind of good. But anyway, so we do this if you're going to do it. I don't know. This is private insurance, so this can be costly. So we offer all of these things. These are things that you will be offered in your doctor's office when it is offered in a midwifery practice. There's a lot of language around it, giving you lots of informed decision making, so you can say yes, you want it, no, you don't want it, and what those options are. So hopefully that is helpful. If you have any questions, of course, you can always comment on our Facebook feed. You can follow us on Instagram. Share this with your friends. This is really confusing information. And we have people that we are deciding to have an out-of-hospital birth for their first time. They might have had 3 or 4 babies, and they don't know this information. This stuff has never really been explained. And it's really kind of fascinating once you start to unravel what this information is and what you're going to learn from it and how will you move forward. It just helps you really understand what's going on with your body and giving you a voice to what's going on. So there you have it. If you have any input, comment below. And again, thanks always for joining us, and we'll see you next week.